Good evening. It is a pleasure to be part of this certificate program from the Indian Society of Transplantation. I'll be talking about post-renal transplant drug toxicity. As a nephrologist and as a pathologist, with renal transplant being so successful over the years, we have to know about this entity to be able to diagnose it early and try to manage whatever best we can these patients who are already on very doses of cyclosporine. So calcineurin inhibitors, which are primarily cyclosporine or tacrolimus, are the mainstay of most standard immunosuppression protocols. Kidney transplantation, if we see over the years, has achieved excellent short-term outcomes, but long-term outcomes have not improved significantly after 1980s. And this is when these calcineurin inhibitors were started as a therapeutic module. So chronic calcineurin inhibitor nephrotoxicity is a contributing factor for late allograft loss and chronic renal allograft damage. And it is now, with more and more data coming in, it is said to be universally present at 10 years, even in grafts with excellent function. So how do these calcineurin inhibitor act? Basically, calcineurin is a calcium-dependent serine threonine protein phosphatase that is important for the immune system regulation. So these calcineurin inhibitors, that is cyclosporine and tacrolimus, which are both isolated from a fungus, they do not have structure similarities, but have similar therapeutic mechanisms and toxicity, about which I'll talk a little later. And they share the same nephrotoxic side effects with indistinguishable histological lesions, which primarily involve the tubules, arterioles, and the glomeruli. And this nephrotoxicity is not necessarily dose dependent. And that is why it's important to understand that it may occur even in allograft recipients who have normal calcineurin levels in the serum. So the term CNI-induced toxicity is used for both cyclosporine or tacrolimus induced changes in the kidneys, in the grafts. So let us know how do these calcineurin inhibitors act. So basically the CNIs, they bind to the cytosolic protein immunophilin. In the case of cyclosporine, it is cyclophilin. And in the case of tacrolimus, it is the FK binding protein. So once these CNIs bind to the so-called immunophilin, they inhibit calcineurin. So what does calcineurin do? Basically, calcineurin causes activation of the nuclear factor for activation of T cells. So when they block calcineurin, this activation of NFAT does not occur. Once this activation does not occur, it is not translocated in the nucleus and does not cause transcription of the cytokines, basically interleukin-2. So what are these doing is basically they are blocking the calcineurin activity, and calcineurin basically promotes T cell activation. So they in turn are blocking the T cell activation. Whatever the therapeutic doses which are used in these allograft recipients, they block approximately 50% of the calcineurin activity and thus allow for an effective immune response despite of these patients receiving these calcineurin inhibitors. So when you look at the effects of these calcineurin inhibitors, they cause both structural and functional toxicity. Functional toxicity is related to the vasospasm that is caused on the arterioles. The structural toxicity is something what a pathologist looks at. So the histological changes which can occur in the tubules can be early minor changes, which are basically because of the single cell necrosis. It may produce giant mitochondria and isometric vacuolization of the tubular cells, basically the proximal tubular epithelial cells. And the late minor changes may be microcalcifications. When these occur, that is isometric vacuolization, these are all reversible. But as the later changes come in, like microcalcification, they are partially reversible when we are talking of tubules. In terms of arterioles, when we look at early minor changes, it basically causes smooth muscle cell swelling and endothelial cell injury. It also causes single myocyte necrosis. Again, at this stage, this change is largely reversible. However, at a later stages, You may have hyaline deposits in the vessels and intimal fibrosis and onion skinning, which leads to sclerosis, and then they become largely irreversible. Apart from these minor changes, there can be major changes in the arterioles, which are basically related to the thrombotic microangiopathy-like lesions, which I'll be showing you later. In the glomeruli, the early minor changes again are related to the endothelial cell injury and necrosis. And again, these are largely reversible. Reversible in terms of decreasing the doses of calcineurin inhibitor. And the major changes which can occur are again thrombotic microangiopathy-like lesions, which then go on to cause major changes in the glomeruli, which are related to splitting of the glomerular basement membrane, which we use the terms like transplant glomerulopathy. And these changes then become largely irreversible. So these secondary changes which can occur in the kidney are basically the striped interstitial fibrosis, and in the later stages, you can have focal or segmental glomerulosclerosis, then leading on to global glomerulosclerosis. So sometimes in the literature, you can look at terms which are used like acute and chronic. But when you look at CNI arteriolopathy and glomerulopathy, they can develop within days to few weeks. And therefore, the terms acute and chronic are practically inaccurate. You can talk of early lesions and then the late lesions. The histological features are only suggestive of CNI toxicity. So we need to remember that none of these changes which I have talked about are specific for CNI toxicity. They have to be used, the diagnosis has to be done in terms of the clinical context, and also to look at changes which may be present associated with rejection. So that is why none of these is very specific for CNI toxicity. These are changes which have to be ligament conglomeration. So let us look at the pathology of CNI toxicity. So as I said, in CNI-induced toxic tubulopathy, it is one of the changes which can occur early in the course of therapy, characterized by isometric vacuolization of the tubular epithelial cells, which is primarily in the proximal tubules, and it occurs due to dilatation of the smooth endoplasmic reticulum. You can also see some amount of isometric vacuolization because of other agents which cause osmotic injury. But that isometric vacuolization is usually due to dilatation, formation of the phagolysosome, so dilatation of the lysosomes. So as I said, this is not a specific change. It can occur due to osmotic injury also. The other lesions which you can see because of CNI-induced toxic tubulopathy are dystrophic microcalcifications and giant mitochondria. When we talk of giant mitochondria, we of course have to look at these in the electron microscopy, and often these cells show single large mitochondria in the cell. This is a photomicrograph to show isometric vacuolization in the proximal tubular epithelial cells. So you can see these tubular epithelial cells are all swollen. These are the proximal tubules, and they are filled up with these vacuoles in the tubular epithelial cells. When you look at these in the periodic acid shift stain, you can see that usually the brush border is maintained. And this is a cytoplasm which is showing this isometric vacuolization. So with retention of the brush border of the tubules. And the early change, which I'll show you in another figure, is also this. You can see this vacuolization in the myocytes, which is also an early change because of CNI toxicity. So the vascular lesions are caused by the release of vasoconstriction, which cause ischemic injury. The most characteristic changes are seen in the afferent arterioles and the small arteries, which have 2 layers of smooth muscle cells. And for these, we use the term CNI arteriolopathy because these are the arterioles which are involved. The early CNI-induced changes in the arterioles are the marked swelling and ballooning of the medial smooth muscle cells, which causes large clear vacuoles, as I showed in the last picture, which is caused by dilatation again of the endoplasmic reticulum. And the common change which occurs is the intramural hyaline deposits. Basically, these are nodular protein deposits replacing single necrotic smooth muscle cells of the media. Rarely, in severe cases of CNI toxicity in the vessels, you can see thrombotic microangiopathy-like changes. So let us look at myocyte vacuolization. So you can see that the afferent arteriole is showing these large vacuoles in the myocytes. So this is again an early change of CNI toxicity. And as a pathologist, we are required to tell the clinician to monitor the dose of CNI in these patients. Similarly, you see an arteriole which has these myocytes, which are showing these large vacuoles in the myocyte cytoplasm. The other change, as I talked about, when you have single cell necrosis of the myocytes, it is replaced by these nodular deposits of hyaline. So these are the nodular deposits of hyaline that you see, and usually these are towards the myocyte side as compared to hypertension and diabetes, which show you the intimal hyaline which is there. So here also you see the myocyte which is showing you these hyaline deposits, and this is a circumferential deposition of hyaline in this arteriole. Here also you see this hyalinosis which is seen in these, and this is a periodic acid shift stain to highlight this hyaline deposits. How do you know that this is a periodic acid shift stain? You can look at the basement membrane of the tubules, which are highlighted very nicely by the periodic acid shift stain, and also the Bowman's capsule. This hyaline deposits can be circumferential, which is obliterating the whole of the almost partial lumen of the arterioles, the afferent arterioles. So in the BAMF, if you see the BAMF lesions cause these arteriolar hyalinosis. 0 is when you do not see any typical lesion, which is suggestive of calcineurin inhibitor-related arteriolopathy. AAH1 is when you have only one arteriole involved without circumferential involvement. AH2 is when you have more than one arteriole involved without circumferential. And AH3 is when you have even one arteriole which has a circumferential involvement, independent of the number of arterioles which are involved. So, as I said, in severe cases, you can have, arteriolar fibrinoid necrosis and features of microangiopathy. So here is an arteriole where you see complete loss of the myocytes with presence of these fragmented RBCs in the wall. Now coming on to CNI-induced toxic glomerulopathy, basically it occurs because of the toxic endothelial cell injury, which can be minor or severe. And also because it is a protracted or a recurrent mild injury. So when there is a recurrent mild injury, it causes widening of the lamina rara interna with subendothelial new lamina densa formation, which leads on repeated injury causes GBM duplication, which is generally focal and segmental and also is associated with mesangial expansion. And we use the term CNI glomerulopathy, and more commonly, if you have the chronic changes, as transplant glomerulopathy. So when you look at this in an HE stain slide on a graft biopsy, you can see that this glomerulus is showing you some thickening of the glomerular capillary loops with partial obliteration of the capillary lumina. When you look at it under the periodic acid shift stain, you can see, as I said earlier, there is subendothelial expansion by this pale looking material. And if you see closely, the afferent arteriole also is showing you these hyaline deposits in the wall, along with subendothelial, some pale areas in the subendothelial area. And if you look closely, you can see this duplication, segmental duplication of the GBM, which is better highlighted in a periodic acid silver methenamine stain, where you can see this duplication of the glomerular basement membrane. So this is what is transplant glomerulopathy. So as a lesion, transplant glomerulopathy can occur both in CNI-induced toxicity and also as a part of chronic antibody-mediated rejection. So we have to differentiate between these two conditions based on the other features that we look at in a graft biopsy. So when we look at it in electron microscopy, transplant glomerulopathy will show you the subendothelial widening. And you can see this multilamelation that you see and the duplication of the glomerular basement membrane. So you will see when you look at it in the light microscopy, you will see two layers of the glomerular basement membrane which are running. So this is known as transplant glomerulopathy. As per the recommendations of the BAMF 2013 meeting report, It is said that EM should be done in all biopsies for detection of early changes of transplant glomulopathy. For all biopsies when they are more than 6 months post-transplant, and for cause biopsies when they are 3 months post-transplant. Now coming on to toxic glomulopathy, which is very severe. And the severe toxic glomulopathy presents as thrombotic microangiopathy. You may or may not sometimes have fibrin thrombi, but it causes damage to the wall with presence of fibrinoid material and fibrinoid necrosis. The thrombi resolve with time and they cause GBM remodeling with duplication of the peripheral glomerular capillary walls. So you can understand that this GBM injury, the injury to the endothelial cells, which may be protracted or recurrent, and a severe injury, both can lead to transplant glomulopathy with duplication of the peripheral glomerular capillary loops. The afferent arterioles feeding the affected glomuli often present with toxic arteriolopathy. So this is to show you the changes in the glomerulus in thrombotic microangiopathy. So generally the hilar pole, if you look at the hilar pole, you will find this area of necrosis, that is thrombotic microangiopathy in the glomerulus. This is again the same picture I had shown earlier. So then the same biopsy, you had these arterioles which were showing you fibrinoid necrosis with presence of fragmented RBCs. And you can see that this glomerulus is showing you ischemic wrinkling of the glomerular basement membrane. When you look at the same biopsy in the Mason's trichome, which highlights the fibrinoid material, you can look at it, the RBCs which are completely fragmented, and this is the swelling of the media with presence of this material and edema even in the hilar pole of the glomerulus. And that is when you have to consider, of course, you have to rule out an antibody-mediated rejection which may be present, and also to rule out a CNI-induced thrombotic microangiopathy. So the other lesions which can occur because of CNI-induced toxic glomulopathy are FSGS, which may be secondary due to nephron loss, associated interstitial fibrosis, hyaline arteriolopathy, and CNI glomulopathy. It could be a collapsing FSGS due to ischemic podocyte injury. Sometimes, as I said earlier, in the later stages, you may have glomulosclerosis due to severe arteriolopathy. So this is to show you the hyalinosis which is occurring in the hilar arterioles associated with hyalinosis in the glomerular ducts, which may later on then develop into a segmental sclerosis. This is a more developed segmental sclerosis where you can see the segment of the glomerulus is completely gone. You can see associated hyalinosis in this glomerulus. So these lesions are also indicative of CNI-induced changes which may occur in the later stages. Often when you look at these glomuli in the electron microscopy, they will not show diffuse podocytopathy. And that is how you distinguish primary FSGS from secondary FSGS due to CNI toxicity. This is again another picture to show you as I said, you may find hyaline arteriolopathy in the feeding arterioles to the glomerulus. And this glomerulus again is showing you hyalinosis and segmental sclerosis. And these are the arterioles which are showing you hyalinosis. So coming on to the interstitial changes, the interstitial changes are usually in the form of interstitial fibrosis, which can be striped or maybe not even be striped. Striped interstitial fibrosis is a term that we use when you have bands of fibrosis, which basically occurs because of an arteriolar involvement, and the area which it is feeding causes striped fibrosis. It is associated with tubular atrophy and glomulosclerosis, and of course, significant arteriolopathy, which is the basis of this interstitial fibrosis and tubular atrophy. So again, a photomicrograph to show you the interstitial fibrosis and tubular atrophy associated. You often find associated hyaline changes in the vessels in these biopsies. This is again to show you the same in periodic acid shift stain. You can look at these two arterioles where you can see this arteriolar hyalinosis in the vessel wall, that is involving the smooth muscle cells. Similarly, here you have this nodular hyalinosis which is occurring into the vessel wall. So this is typical of CNI-induced toxicity as compared to diabetes and hypertension, where the hyalinosis basically is in the subendothelial region. And usually it is not so nodular as you see in an CNI toxicity. So what are the immunofluorescence and electron microscopic changes in CNIT? Immunofluorescence does not show any specific findings. You may have non-specific binding of IgM or complements, as you see in FSGS and other conditions. For transmission electron microscopy, as I showed you, there is endothelial cell injury. You can find reduplication of the glomerular basement membrane, that is the transplant glomerulopathy with multilamelation. You may have enlarged and irregularly outlined mitochondria, and with you may have a few cristae and occasional crystalline material. The isometric tubular epithelial vacuolization is basically because of the dilated smooth endoplasmic reticulum. So this is a nice table from the Hepstein-Stall pathology of the kidney, the 7th edition. Sorry, where they have tried to talk about the differential diagnosis of the various changes that you see in CNI toxicity. So as I said earlier, this isometric vacuolization can occur also because of other osmotic injury agents. And it is important to look at the previous medications. And we also know now that by electron microscopy, the isometric vacuolization because of CNI toxicity is because of the dilatation of the smooth endoplasmic reticulum, whereas because of the osmotic injury, it is because of the formation of dilated lysosomes and phagolysosomes. The thrombotic microangiopathy can occur because of various reasons. One cause is also antibody-mediated rejection. Of course, you will look at other signs for antibody-mediated rejection in the form of C4D positivity, peritubular capillaritis, microvascular inflammation, and of course, DSA. CNI arteriolopathy, as I said earlier, this hyalinosis can be seen both in diabetes and hypertension in pre-existing donor diseases. So in diabetes, basically the clinical history is important. You will also find nodular glomerulosclerosis, and of course, the hyalinosis that you see basically is in the intima. In hypertension, you may also see a similar type of hyalinosis, but again, you also have intimal fibroelastosis, and the arteriolar hyaline is basically subendocrine. In pre-existing disease, of course, you can look at it in the 0R implantation biopsies, and primarily it is either due to diabetes, hypertension, or age-related. In chronic in vascular rejection also, you can have sometimes changes in the arterioles, but of course you will have other features, and then the list is long. In CNI glomerulopathy, you have to rule out a possibility of chronic antibody-mediated rejection, and also sometimes T-cell mediated rejection. Of course, you look at other features to make a diagnosis of CNI associated or other causes of glomerulopathy. So now, after covering the most important topic, that is CNI-associated toxicity, which is the most commonly encountered, let us look at other drug toxicities in the transplant biopsies. So the drug-induced acute tubulointerstitial nephritis can occur because of various drugs that these patients receive, maybe antibiotics and other drugs. And basically, it occurs due to an acute allergic reaction. And because it is an acute reaction, it may also overlap with T-cell mediated rejection and is also modulated and inhibited by immunosuppressions like steroids. So that is why you may not have a clear-cut picture of an acute tubulointerstitial nephritis with a lot of overlap with TCMR. What is more important is to look at the temporal relationship between the drug administration and the onset of the allograft dysfunction, development of a rash or a fever or eosinophilia, which may be associated with an allergic reaction. The histological clues which help us to delineate whether this is related to a drug-related tubulointerstitial nephritis in a graft biopsy is that the inflammatory cells usually predominate at the corticomedullary junction, and spare the cortex. This is number one. The second is if you find ill-formed small non-necrotizing granulomas, it gives a clue that it may be drug-induced. The other important thing which is to be considered is mTOR inhibitor toxicity. So initially rapamycin was it is again a drug which is isolated from the fungus. Agents like sirolimus, everolimus, they were being used to prevent the toxicity of CNI at one point of time, to lower the steroid or CNI exposure and to limit the chronic graft injury which was occurring because of fibrosis. But they have their own toxicity. The mode of action and toxicity of the mTOR inhibitors is because this mTOR is involved in the cell cycle. It is a cell cycle for the cell cycle regulation. So what happens that when you block this mTOR's action, there is cell differentiation and proliferation are inhibited. It also causes altered VEGF production, which causes endothelial cell death and thrombosis. So many of these allograft recipients presented with thrombotic microangiopathy. It also, because of the altered VEGF expression, causes podocyte injury, and then it may lead to proteinuria. So what are the indicators of mTOR inhibitor toxicity clinically? These patients will present with prolonged episodes of delayed graft function in the initial phases. If they're given in the initial phases, they may present with proteinuria and also microangiopathy. As I said earlier, sirolimus is known to produce thrombotic microangiopathy. So the histological features will be, you will see tubular injury. You may find FSGS, which may or may not be associated with varying degrees of podocytopathy. And of course, in the severe cases, you have thrombotic microangiopathy. So at this point of time, as a pathologist, you need to look and see if the patient is receiving any mTOR inhibitor to tell the clinician that has to be stopped. And that is how the patients then respond. Another drug which sometimes has to be talked about is an antiviral drug toxicity. This toxicity, as compared to CNI toxicity, is dose dependent. And volume depletion in these patients, varying causes of dehydration, may predispose to toxicity. Other risk factors are older age and pre-existing renal impairment. It basically causes a functional tubular injury in the form of proximal injury, distal tubular acidosis, or Fanconi-like syndrome. Sometimes in rare cases, it may cause crystalluria and nephrolithiasis. So for example, it is known that antiviral drugs like acyclovir and ganciclovir they lead to needle-shaped crystals in the urine. And a drug which is used generally for drug-resistant CMV infection, that is cytomegalovirus infection, that is foscarnet, causes crystal nephropathy, and it appears like small calcifications in the tubular epithelium, which can be highlighted by the von Cosa stain. So to conclude, drug toxicity can significantly affect the kidney allograft function and overall survival. CNI has revolutionized kidney transplantation and continues to have a widespread use. But what is important as a nephrologist to understand is what is worse for the graft, CNIT or the increased risk of rejection associated with the withdrawal of CNI. So what is more important is a CNI toxicity management. You have to manage the adverse effect, often with additional medications, and avoid high plasma CNI levels while balancing the risk of allograft rejection. I think that is the most important message from this talk, that you have to basically manage the CNI levels and see whether it is not causing any toxicity to the graft kidney. The other thing which, as a pathologist, I would like to again reiterate is that there is no histological lesions which are very specific for CNI nephrotoxicity. It is basically a diagnosis of exclusion. As a pathologist, every pathologist should look for other causes which may be responsible for example, hyalinosis. Look for other causes which may be responsible for transplant glomerulopathy. Considering everything, then you have to see whether there is associated rejection or you have rejection with CNI toxicity, because we know in a graft biopsy, you can have multiple lesions at the same time. So basically, you have to know about the whole picture before you can make a diagnosis. There are some novel immunosuppressive regimens, but there is lack of sufficient evidence for them to reach the bedside and replace CNI as per now, whatever the literature is. But of course, there are a lot of clinical trials which are being conducted to see whether CNI can be replaced so that you have better long-term outcomes of these allografts in the future. So thank you so much for the listening, and I will be happy to take any questions.